Welcome to Reducing Inequality and Risk in Childbirth. Thank you for joining us for this webinar in our Women's Rights in Healthcare series. My name is Olive Lewin and I'm one of the partners in the Clinical Negligence Department at Leigh. Today's subject is particularly topical given the background of the Black Lives Matter campaign, the coronavirus pandemic and its disproportionate effect on the Black ethnic community, and the 2019 Embrace report, which shows that the risk of maternal death continues to be significantly fivefold in Black women, threefold in women of mixed heritage, and twofold in women from Asian backgrounds. We've got two really brilliant speakers who will discuss the role of the midwife, current issues in the delivery of care, and possible solutions. All of our webinars are being recorded and will be available to view on the YouTube channel. So, as I said, our speakers today are Elsie Gayle and Clotilde Abe. Elsie is an independent midwife and founder of Midwifery Conversations, which is a holistic, non-governmental organisation dedicated to sustainable and culturally safe maternity services. She was awarded an honorary fellowship by the University of Wolverhampton in 2017 in recognition of her contribution and passion towards midwifery and her commitment to the BME community and women's rights, particularly in the areas of childbirth and mental health services. Chloe is founder of Prosperities, a mental wellbeing social enterprise which supports Black and South Asian mums in Lambeth and Southwark, and is co-founder of the 5 Times More campaign. She works full-time in fetal medicine, the Fetal Medicine Day Assessment Unit in a South London hospital, and she's also the co-chair for Lambeth and St Thomas's Hospital Maternity Voice Partnerships. Chloe, it must have been a very busy few weeks for you and the team. You've all done a huge amount of TV and media work, and I know that you've put questions to Parliament, and I also know that you've got to dash off after this webinar to do another conference. I'd be really grateful if you could tell us about the campaign and your aims for it. Okay. So over to you, Chloe.
Thank you. So just a little bit about 5 Times More. It was co-founded by myself and Tineke. We are both mums of 2. It was co-founded last year, so last year, May 2019. So 5 Times More is a grassroots social enterprise that campaigns to highlight the disparities in maternal outcomes for Black women in the UK. While it's relatively safe to give birth in the UK for Black women are still 5 times more likely to die in childbirth than white women. So with the campaign, what we want to do is to raise awareness of these disparities in childbirth and the experiences of Black women. We want to empower Black women to make informed choices throughout their pregnancy and after birth, and want women to advocate for themselves. We want to close the gap on maternal health experiences of Black women and want to empathise Black women's voices in discussion in terms of improving maternal safety. So one thing we don't want to do, we don't want to scare women, we want to empower them with knowledge and support. So we came up with 5 steps for women, or 6 steps for women because we added one more. We co-designed 5 steps for partners with a few dads. And recently we collaborated with the Royal College of Obs and Gynae, so RCOG, to write 5 steps for health professionals. I'll go into more of the steps later on. As well as empower women, we want to create long-lasting change and have asked people to write to their local MP, sign the petition, which has over 187,000 signatures, and it will also be debated in Parliament we haven't got a date for that yet. We ask people to take a selfie like this, which represents 5 times more. We've told people to, you know, spread awareness and share, you know, our page and support wherever they can. So last month in September, we held the UK's first Black Maternal Health Awareness Week. We had unique daily hashtag and action for people to get involved in, and a very interactive virtual event. On the event, we had 2 panel discussions, one with health professionals and the other with mums. And what we learned from the health professional event was we need to address Black women's health. We need to have Black women's health studies or some sort of research. Another thing that we realised was we can't pinpoint the shocking statistic to one thing, is multiple factors. And the history of Black women in medicine should be taught as part of the curriculum. And this came about because one of the student midwives on the panel mentioned, when I asked her, did she know about the statistic? Was she taught about, you know, Black women's health and etc. during her studies? She mentioned that in her first year of being a student midwife, she saw one slide, and that's where it mentioned about Black women. And since then, she's never seen any other thing in her modules. And then what we learned from the mums was dignity, respect, compassion, and listening were fundamental requirements that are currently missing when administering care to Black women.
Okay. Just, can I just ask you something? You mentioned that you wanted to raise awareness as part of the 5 times campaign. How are you doing that at the moment? So
at the moment, it's with social media. So it was social media, Instagram, Twitter, which were really, we have interacting audience with that. Our events, we use that to raise awareness. We're doing a lot of media. So recently we were in The Guardian, HuffPost, ITV News. We did a bit for BBC. We actually submitted evidence to the Health and Social Care Committee, and we spoke about, you know, women not being informed, so having birth options. So we spoke to 415 women who participated in the evidence that we gave. And so I'm looking over at the sheet. 55% of the women felt they were given enough evidence about vaginal birth. 78% of women did not receive evidence or guidance on informed decisions. 70% of women were not told about water birth. 73% of women were not told about C-section, and 85% of the Black women were not given advice about assisted birth.
Right, okay.
A lot.
Yeah.
So
yeah.
we were just fighting on social media just to get more awareness, and any sort of coverage we can get, we're just using that.
Okay. You mentioned the 5 steps. Can you tell us a bit more about those?
Yes. So we have, 6 steps. It depends which one you're talking about. So we have 6 steps. So the first step is speak up. We're asking women to speak up. You know, if you feel something's not right, speak up about it. Don't stay silent about it. We're asking women to find an advocate. So if you've got someone to support you, a birth partner, let them know about your plans in terms of your birth plan, just in case you are in a vulnerable state and you're not able to speak up for yourself. Let someone advocate for you, but also advocate for yourself if you're able to. Seek a second opinion. A lot of women don't know their right. They're not aware that they're allowed to seek a second opinion and change midwives if they want to. And we're telling women to trust their gut. If it doesn't feel right, it's probably not right. You know your body, it's your body. We're asking women to do their research and not just to go on Google and talk to a friend. Use trusted websites like patient.org, nhs.com, and the NICE guidelines. And then the sixth step, which we recently added, was document. Make sure everything is documented. If you were given medication or refused medication, make sure it is documented. So that was the mum steps. Did you want me to go through the other steps as well?
Yes, please. Yes, please.
Then we have the partner steps, and we said partners need to be active. But active also means be present in the moment, because I know as a mum of two, when I was pregnant, I didn't want my partner rubbing my back. So I wanted them to be active, but not active enough as in touching me, just be present in the moment. Be her advocate, and this is what I mentioned before. If health professionals intervene, ask for the reason and make it clear and clearly communicate that with your partner when she's able to understand. We're also asking partners to do their research. Don't leave it up to the pregnant women and your partners to do the research as well as her. Do it together. You know, attend antenatal classes if you need to, antenatal appointments, hypnobirthing. If you're able to, recommend that you should attend. Be prepared and be flexible. We know not all pregnancies are the same, not pregnancy goes as we plan. So we also tell partners, you know, be flexible with their birth options because things might not go to plan. And we also tell partners to look after yourself. You know that saying, you can't pour from an empty cup. You know, you can't look after a woman if you're not in the best frame of mind. So we tell them to look after themselves and to support their partner emotionally, you know, and yeah, so that's the partner step. And then we have the professional steps, which is, sorry, I need to get it up. The professional step, we have listen. From the work I do with 5 Time Wars and Prosperities, we get told that a lot of women feel like they're not being listened. So what we wrote down is listen. If a pregnant woman expresses concerns, feels like something's not quite right or she's in pain, please take her seriously and listen to her concerns. Remove any barriers to communications. So for all women, but especially those who language barrier is you know, is an issue, or language is a second language, it is important to make time to listen and talk with them so they know what is happening and they are in control of their situation as much as possible. The translation service, if required, and remember that bodies and language tone can also help a woman feel ease. Number 3, we have check you're providing clear information. So after you explain a woman's option and made recommendations about her care, it is important that you recap the information and check she understands the choices available to her. And this to me was the most important step, because working in hospitals, I realized that some women just nod and agree, but they're not too sure what you said, and some of them are a bit too shy or just generally don't want to feel like they're bothering you but asking more questions. Completely documentation. So we also tell health professionals that they need to complete their documentation and make sure they document, and be a champion. So inspire others to champion positive change in maternity care, and this will help improve for all women, and support and research as well.
Fantastic. And I think it's fair to say that, I mean, although, you know, you set up the 5 Times More campaign, I mean, what you have put together, you know, all these steps really apply to all women across the board. Yes. You know, it's not just Black women, you know, it is actually all pregnant women that these steps apply to. You know, so and then can you tell us a little bit about Prosperities as well?
Okay, so I founded Prosperities from my own experience of being a mum, and not having a safe space and not feeling included when I went to children's centres and feeling like it wasn't a place for me. So Prosperity is a maternal wellbeing social enterprise, which is designed to support Black and South Asian women in Southwark and Lambeth during the perinatal period. What we focus on is raising awareness, prevention, and early intervention. So Prosperities is divided into two sections. We've got the peer-to-peer support section and the social gathering section. With the peer-to-peer support, we do weekly catch-up over the phone, face-to-face, attend antenatal appointments, so scans as well. We signpost women to services. We do weekly emotional support. So I'll be on the phone to the mums, speaking to them generally about how they are. And what we do, we empower women to make informed decisions, give women information about their rights, signpost women, which I said already, use spaces in the community that matters, like children's centres, libraries, park, support them with their birth plans and breastfeeding support. And then the social side is we host 2 events per year, one on perinatal mental health and the other to do with all things pregnancy. And last year we had an event and we had a partner from Leigh Law who spoke about consent. Before COVID, we were supposed to start birth preparation course at the local children's centre, but due to COVID, we weren't able to do that, but we will be doing it online very, very soon. Also, because of COVID, we are now able to support more women around the country. So we no longer support women just in Lambeth and Southwark, but we're all over at the moment. And we've seen a high demand of support for Prosperities due to, COVID-19 and Black Lives Matters. A lot more mums are coming with, depression, anxiety. A lot of mums are coming with, they're not feeling empowered. They feel like they're not being listened. A lot of mums are coming to us about not feeling safe and supported when they challenge health professionals. And yeah, that's mostly what I do, Prosperities.
And can I just ask, you say that you signpost people. So if somebody came to you with certain mental health issues, what would you do? Are you sending them to their GPs or giving them leaflets? How do you help them?
So I have professionals that I generally talk to and I do prosperity around. So I signpost them to them. So right. I call like a therapist who I talk to, a counsellor, and tell them I've got a woman, this is what's going on. Can you support her or can you signpost her to somebody else? I'm not a trained mental health professional, so I tend not to do it myself. Yes, I signpost them to services which could give them better support than I can.
Okay, lovely, thanks. Okay, well, what I'm going to do is, if it's all right with you, Chloe, is hand over to Elsie now. So yes, if I can hand over to you, Elsie, and if you can just sort of, let people know what the role of the midwife is, and the problems that can arise, and what you think the solutions are.
Okay, so good afternoon, everyone. It's really great to be here and to be able to speak about the role of the midwife, which, to be honest, is something that I think is left behind on a lot of occasions, although the role of the midwife is so important to all the things that Chloe has been talking about. So I have to say that many of the things she has raised in her campaigning are some of the issues that we have come across as well. So midwives, and in the UK, we are so fortunate in as much as we have been a regulated profession since 1902. We were regulated before nurses were regulated, in fact. And we have had a very strong role in making mothers and babies' lives better. But we are a profession. We have had a midwifery education that is recognized. We are highly regulated. In fact, I would say we are one of the most highly regulated professionals in this country. We have a body of knowledge, and UK midwives in particular are recognized right throughout the world as a discrete profession that is effective. We are responsible and accountable. We work in partnership with the women. So I'm reading here from the ICM definition of the midwife. We work in conjunction with the women and their families to give them necessary care and support and advice. So we can do that pre-pregnancy, for pregnancy, labor, birth, and the postpartum period. We conduct births on our own responsibility, and we provide care for mother and newborn and the infant postnatally as well. So within that role, we are able to work as autonomous clinicians, delivering care on our own cognizance. But we also have the responsibility to recognize any deviation from the norm and refer to the appropriate clinician for advice, support, and further care. We can do this in the woman's home. We can also do it in hospitals, standalone birth centers, and in private clinics as well. So this is how we operate in the UK. I've also had the great pleasure and privilege to work abroad in the Caribbean and also in Africa, where I was able to utilize my skills as a midwife, but also as a nurse, to deliver care for mothers and babies and their families. So if you look at our role, what you will see is that we are a very important part of the equation in terms of supporting good societies. And within the societies, the communities that exist there. And it is only when our role, we're not able to fulfill our role that we have problems. So you hear Chloe actually describing some of the things that Prosperities is seeking for women. So for women's voices to be heard. And within that, we need to really be developing therapeutic relationships, relationships that are positive, that support the empowerment of women. So women empower themselves out of that relationship so that they feel good about themselves, they journey well, whether they have, irrespective of the risk, actually, a midwife will actually be involved in the care of a woman for her benefit. So that's primarily what midwives do. We have really good policies in this country. In fact, the extant maternity policy, Better Birth, actually describes the ability in policy for women to have choice and are able to choose. For us, and particularly those women who have really poor outcomes, as described by the Embrace report, where Black women, women of African descent, are 5 times more likely to die. What sits behind that also is the morbidity, the damage, some of which is apparent and some of which is not apparent. So we have things like maternal mental health causing concern. But when you have relationships where women can journey well, make a choice for things that they think and recognize for themselves as safe, where their needs and their values are met, then they stand a better chance of having better outcomes. So basically that's what a midwife does, but there are structures within which she has to work. So she works within organizations and their cultures and their how they're organized, but we're also regulated and we work within that structure as well. But then we have the societal structures within which we have to work. And all of those things certainly impact how we are able to work as midwives. And that's kind of basically what I've been spending my time looking at. And I've been looking at it over a number of years, since about 2001 in actual fact, when I recognized that there were some impacts that weren't supporting good midwifery practice.
And do you think that there's enough investment within midwifery? You know, when I say investment, what I'm talking about is, you know, are there sufficient numbers within the various institutions? Do midwives need to, are there areas of learning that midwives need to have? Certainly it used to be the case, and I know that you initially were trained as a nurse before you became a midwife. Do you think that you have more insight into women who are becoming ill than midwives who haven't had the initial training as a nurse?
I think some people would say that. I mean, I'm clearly going to be biased because I've already had that training, and that training is actually embedded in me. But some of it comes also from my own upbringing, you know, how your mother mothered you and things that you took on board from that as well, how you look after people, nurse them, and so on. I wouldn't like to say that it is a defining factor in terms of certainly my work, because I'm sure that midwife only trained midwives, so to speak, may say otherwise. What I can say is that well-trained midwives should be able to, and I have seen them pick up things which nurses may also be able to pick up. So I wouldn't, there's a lot of questions around whether midwives should train as nurses first. What I can say is that there is a huge difference. These are two separate professions, albeit they are regulated by one regulator, one board. But they are two separate professions. Their focus, in essence, is about sustaining, preserving, and nurturing life. But midwives, in essence, primarily deal with a normal physiological function, whereas nurses, their trend is a little bit different. So I wouldn't say yes to that, Olive, to be honest.
Right, okay.
Yeah.
Okay. So what do you think the issues are around inequality and risk where childbirth is concerned?
This is a very huge topic, right? And I've spent a lot of time because I couldn't, so what happened to me was that I trained here. I worked in very different units in this country, up and down the country. And then we had the opportunity to work in the Caribbean and then in Africa. When I returned to work in the UK is when I recognized that actually I couldn't function as utilizing the whole role of the midwife, using structures that should work weren't really working as well as I thought they should have or used to work. So then I began to take a really good look at, why this was. And I don't think we can actually cover everything here, but what I can say is that we have really good policies for midwifery care, maternity care. But bringing the policy down to the level of the frontline worker is really, really difficult. So the aspiration of, say, for example, continuity of care model, everybody says, yes, it is, it achieves the best outcomes, irrespective of the risk of the woman who is being cared for and her family. But actually getting the continuity of care model embedded and sustained so that we can actually achieve bringing down the 5 times more and rising statistics, that is so hard, really hard. So it's been tried, I think it was 1993, in changing childbirth, same model. A couple of models were enacted in the UK, in England actually. They've fallen apart, gone by the by, despite achieving really good outcomes in terms of the physical and the mental well-being for the women and their families. And these are things that they talk about into old age, to be honest. The midwives who work them, it's a very different way of working. Not all midwives want to work that way or actually can work that way. But when it actually is achieved, is to the satisfaction and the physical outcomes for mothers, babies, and midwives.
Can you just explain a little bit more about the continuity of carer model, and just explain it to people listening to this webinar?
Okay, so it's simply this: the mother and the midwife begin the journey. It could be preconception, and they journey through pregnancy, labor, birth, and postnatally. So in this country, we are able to work up to 6 weeks with women. They develop a relationship of trust and confidence. And in recognizing that, in fact, no one midwife could actually deliver 24-hour care to a woman and her family. You need to have more than one. So at the moment, I'm working a model with someone who used to be my manager in the NHS, and we work very closely together to deliver this sort of care. One leads for the woman, and the other one is the backup midwife. And we work like that all the way through. We do the initial visit together. We may do some more visits together. We develop a relationship. We learn about the couple, well, certainly the woman and her support system. They learn about us. It's more of a conversation. The visits, they're timely. They certainly are not rushed. And we listen, we support, we give evidence, we share information, and the woman makes her choice. It may be that we don't agree with the choice, so we may have a further discussion. And all of these things are based in evidence. So for example, we now have the Montgomery ruling, which actually talks about how we consent people. These things are really important because we are not the decision makers for women. They decide. We only give information to help them to make or to make an informed decision. Because at the end of the day, when we step out of their lives, they're left to pick up whatever the pieces are, positive or negative. So we continue this journey. It may be a single, one of us at a time doing the visit, but we certainly know the both of us. They certainly have our telephone numbers. We are both together at the birth. And then postnatally, maybe the initial couple of visits together, and then we sort of just generally tail off. But the thing about it for us is that we begin the journey knowing that it is not about us. It is about this mother and her baby and her support system. So there is inclusion of her partner or her mother, whoever it is she has around her, and to support that family unit to the best that they can possibly achieve. We also have the benefit of referral. So we will refer anything that is abnormal or anything that needs review. If she's having, for example, constant headaches, we will seek an opinion. And the beauty of that is that we are able to have this professional discussion with the relevant clinician, so to speak. There is a problem for working like this because we don't work in the NHS, Yvonne and myself. We work for a company. We have to do that because the insurance, the professional indemnity insurance is an issue. And at this moment in time in this country, there's only one company that has the ability to give insurance. So we work with that company now. But it used to be that independent midwives could have their own insurance, and I think we are working towards that again. So the importance of this is the midwife being able to work to her role and the scope of her practice as an autonomous clinician. Basically the same way that barristers will work, really. You know, you are regulated, you take time out to work with people in the way that you have been trained and prescribed to do. You take this very seriously, you recognize what it is you're doing, how it is you're making a contribution to the society and the communities within that society, and you're able to do that. But you have to be supported by the structures around you. And I think that's part of the problem. Sometimes the structures fail us.
And so, but the thing is, you know, your scenario sounds like an idyllic scenario, really. But for most women, they will go through the NHS system. And are you saying that there is no continuity of carer in the NHS structure?
No, I'm not saying that. What I am saying is that it is a challenge for various different reasons, really. The culture of the organizations within which the, you know, in the NHS, the different NHS trust providers, for example, they're working at a strategic level with women who are actually at the front line. So they need to create the structures within that system to allow the frontline midwives to actually operate on the front line with the women, whether it is that they create, so the maternity better birth, the policy talks about the choice where women have a group of 6 to 8 midwives who are looking after a caseload of women in the way I've described. So we've had that happen before in the NHS in London at King's. So the Albany practice had been set up and it did work really well in terms of mitigating and managing risk. So we know it can work. The other thing is not all midwives want to work in that way or can work in that way. So for example, somebody like Chloe with 2 young children, it would be a bit of a challenge for her to work like that unless she had really good childcare, because you're on call for a certain amount of time. And then the other thing about it is that the fact is we do not have enough midwives in the system now. There have been quite a few studies that have been looking at the workforce situation. We certainly have not had a lot of success in developing the numbers of midwives, and that's been over a number of years, many years in fact. And as midwives leave and not being replaced, or the issues in the workplace culture, so for example, bullying has been a massive feature, not just in the NHS, right across other organizations as well. So the workplace culture, all these things impact how it is that midwives inside an organization such as the NHS, which is enormous, it impacts how we can actually work.
Okay, just looking at, the risks in childbirth, and talking about the sort of the morbidity and the mortality, and the areas that are higher risk. And if we tie that in possibly to the 5 times more campaign and how they impact. So for example, I was reading that a great number of women suffer DVTs, for example. Hemorrhage, I know, is a big problem. Preeclampsia and sepsis, a big problem. Certainly, I've had the cases I've dealt with where there has been maternal deaths. It's always been sepsis. So I just wondered if you could touch on the sort of the difficulties that midwives face and mothers face as well when it comes to these awful complications.
Okay, so what I want to put out there right now is that there are hidden complications, and the one that sits really heavily because of the statistics that are hidden is the morbidity in terms of mental health.
Right.
Mental health for the mother, but also for the infant and the midwives, because that's a huge issue, which is a little difficult to kind of get behind, but it is an issue. If we can manage to look after people, if we have enough time to care for people, if we have the structures that support our learning and updating, things should improve. Because a lot of, say for example, let's take sepsis for example. we, in Midwifery Conversations, it was actually started as a community of practice where we were doing a lot of engagement with other clinicians who could bring to us the knowledge that they had, the expertise and knowledge that they have. So we had recently, I think it was last year, November or December time, we had someone come who is a lead for sepsis in one of the local hospitals, who gave us the most amazing presentation on sepsis. And then we had a coroner come to talk to us about the issues for, that they meet in their work that impacts our lives as nurses and midwives. And it began to emerge that sepsis has been a problem for a very long time, except that we didn't recognize it. We didn't recognize it, specialists recognized it, but then the coroner, it actually started coming to light through the coronial process of examining deaths in the NHS and otherwise as well. And I have to tell you that out of that one lecture, well, 2 lectures really, one of our midwives and her friend went on holiday. The midwife developed sepsis, and it was only the fact that the nurse who was with her recognized the signs and symptoms and was able to have this midwife blue lighted into hospital, and it actually saved her life. She was in hospital for 5 weeks where they went on holiday, and it has taken her 18 months to 2 years to actually be able to walk after having, because she did have sepsis. She went to theater twice, once for 5 hours. She had 2 lots of operations, loads and loads of IV antibiotics, etc., etc. And if we have the time and the expertise and the knowledge and the skills, there is no reason why we should be missing some of the things. So the fact of not having enough staff, excessive workload, and listening to people, sometimes we actually are, we then miss some of the signs that we should be recognizing. So it's a very difficult situation, to be honest, and I think we need to be able to work in ways that promote the ability for us to work well and to achieve better outcomes for women. And I think it is achievable, if only we had, the time, the information in order to develop the knowledge and skills to do so.
And just sticking with the mental health issues, is it a big problem? And if so, what is being done about it? Well, I don't know if you can answer those questions.
Yes, no. Because as well as, my practice is outside of the NHS, although I work alongside the NHS now. And these things are really quite important. I support quite a few, or have been doing so over the years, supporting quite a few women and midwives and nurses who have been talking about these issues. So I kind of have a finger on that pulse as well. It is a big issue. I think it's always been an issue, because when I was doing my nurse training all those many years ago, I would meet very old women who would be talking, no, seriously, it impacts, maternity care impacts our lives forever. Where things have gone wrong and not been well supported, people's relationships have fallen apart. Women have had nervous breakdowns because of it. It is so critically important to our lives. Some things are more subtle. So women may have postnatal depression, low grade, for many, many years. Some women have had to lose their children because they haven't been able to, and it is devastating. So we need to really have a good service. So coming back to what you asked me just now, it is being recognized, in as much as I think it was either last year or the year before, a lot of money was put into developing mental health or perinatal support for women in terms of hospitals, trained staff, and training for people like myself to learn about these issues and how to activate support for women. So you hear Chloe was talking about being able to refer women or signpost women by speaking to the relevant professionals. So, and certainly midwives, as midwives, we are able to do that. You know, we do that on a regular basis. And to be able to care for a woman with those needs. So we, Yvonne and I, care for women who have proper mental health diagnosis with or without medication, you know, so, and we're having to make those sorts of assessments on a regular basis during the time of our care anyway for each and every woman that we look after. And it is possible to actually be able to support women. But looking now to women who, primarily women of African descent, who have a lot of other things impacting on them more than, say, for example, your white European woman who is articulate and able to talk about a lot of these issues and seek help and so on. A lot of the women who are now having a problem in maternity services are having problems around mental health. And in the Black community, where we need, I can tell you that because I am part of a carer group in Wolverhampton looking at mental health issues for our community. We need something that is tailored to our needs and values. We cannot just take something off the shelf and expect it to work, because our needs and values for our community are very different in many ways. So it cannot just be a generic support. We have to have something else.
And whilst we're still on the sort of complications, preeclampsia, I mean, is that still a problem? Is it mainly a problem within one community and not another? If you can just sort of touch on that as well.
So preeclampsia, as long as women have been getting pregnant, there has been preeclampsia and eclampsia, right? I was working at the John Radcliffe in Oxford when there was quite a lot of research being done around preeclampsia. And we still do not know why it happens. What we have done, and this is not just in this country, I certainly know in the Caribbean, there's been quite a lot of work done around managing this condition. What we have done is to develop a lot of successful treatments, but it has to be based on the diagnosis of the preeclampsia. So we're looking at communities which seem to exhibit preeclampsia, and we do that. This is primarily one of the reasons we have antenatal care and the ability to look back at what happened in the previous pregnancy, or indeed the familial situation. So if we have a woman with a mother who's had preeclampsia, her sisters had it, then we'll be looking very keenly at that. And then the beauty of the Embrace report, which happens, I think it's a triennial report, but we get it every year. It highlights, you know, the issues that are coming up. So we wouldn't necessarily on the ground see, well, preeclampsia is a problem this year, but the Embrace is able to do that for us. It highlights the things that are coming up. So preeclampsia, we can work with that. We have to work with it because, as I say, you know, as long as women have been pregnant, we've had preeclampsia and eclampsia. And it is one of the main reasons for antenatal care, to detect the abnormality and then refer for treatment, opinion and treatment and whatever else needs to happen. So yeah, see, the role of the midwife, so important, really.
Okay, we've got a few questions here, Elsie.
I hope it's for Chloe as well.
There's a question here from Julie Fagan. Do you see any change for women in labour becoming more assertive and informed now?
So the way I work with women, or Yvonne and I work with women, these women are informed and they have made their choice. By the time we get to labor, actually working in this continuity of care model, there is very little to be speaking about when a woman's gone into herself and she is laboring. We kind of know how we're going, what her basic wishes are, her needs are, and so on. And she knows she can actually relax into it because she knows we won't be doing anything without her consent or permission. We kind of know where she's going. So those things would have already been decided. Having said that, for women who do not have continuity of care, women are encouraged to actually write themselves a birth plan. Right. It doesn't always work. I guess when you're short of staff and stuff like that, it's very difficult then to manage that situation within those. And if it's busy and things are not going progressing normally or physiologically, let me say. So it can happen, but I'm not sure how often it does or does not happen.
Right, okay. Another question, would you agree that it all boils down to the lack of funds, and the World Health Organization holds the purse strings in terms of having enough midwives and CPD, paying them well, offering realistic workloads that they can fulfill their roles, and providing continuity of care?
Well, I think it's a lack of insight myself, and I don't know if Chloe would agree with me. She's sitting there smiling. But I think it's a lack of understanding that if you put the money up front to have good midwifery care, in the longer term, you would have a lot less need for mental health services, both in terms of the children and the parents. And that's just one example. Breastfeeding is another. If you put the money in upfront to increase the breastfeeding, we would be looking at a lot better immune systems further down. So possibly managing the COVID pandemic a little bit better as it stands now, because people's immune systems would be far better. So, I think it's a lack of insight on how to spend your money for the best advantage. There is sufficient money. We know that. Guess why? Especially in this country, because look how many billions has been put out now. We've had to put out in terms of the COVID pandemic. So money's out there, but it's how we spend the money. What are our priorities really?
Okay. Another question, how does the assertion work for Black women who are traditionally not listened to?
Well, I wonder if Chloe wants to say something about that.
Is Chloe there?
I'm here.
Yes.
Just watching. I think I'm not really too sure how to answer it, because I think women not being listened to is such a big topic.
Yeah.
It's so big. I was having a discussion about this yesterday, and it got to the point where we were talking about how we say stuff is how we're being listened to. So if I came into, a maternity ward and I said, I'm in pain, the way I said I'm in pain is how I get supported. So if I came, look professional and I looked a certain way and I said I'm in pain, would I get better support than if I came, with a typical stereotype, jeans, tracksuit bottoms? Would I be listened to? And this whole thing where we have to. So when I was pregnant, I got told to exaggerate my pain, and if I don't, I won't be listened to. And it is these sort of things that we have to do to get listened to, which is really, really ridiculous. I have a lady currently who I'm supporting, and she's not being listened to, so she's always going back and forth to the hospital, and they put it down to she's got severe anxiety and high professional dependency. But that's not it.
Yeah.
She's complaining about, she's having chest problems, and she's got high blood pressure, and she's been told different information, but whenever she goes to the hospital, they're like, oh, here she is again, what do you want? And that's how she feels, and she's a young 22-year-old. Yeah. So I don't know if Elsie can answer it better, but in terms of being listened to as a Black woman, I wouldn't say Black woman, it's really hard.
Yeah.
I just want to say, before you just jump in, I just want to say, I think it's to do with power structures and systems of, I want to say, oppression. How are we seen as women? So it's a gender issue. But I also think it's how we see different communities. So there is one section of the community that I work with who are Pan-Africanists. They will talk about Afrophobia. And they feel very strongly that because they are of African descent, in a world where racism is prominent, I mean, the UN, we are actually in the middle of the decade for people of African descent. So they would talk about the lack of recognition for the human rights of people of African descent and the reproductive justice that sits within that. So they would talk about that. Some people would say it's because I am poor, or some people would say it's because I'm a Roma gypsy, and we've looked after all sorts of people like that. So I think it's more to do with the power structures within the society that we live in, to be honest.
Chloe, there's a lovely message here for you. Someone has written, thank you for your excellent talk and campaigning work, Chloe. Amazing. Your 5 times more website is impressive. I really value the women's stories. We very much value having you working with us at King's College London on the ARC South London Research Programme.
Thank you.
Okay, I think that another question has just come in, and we're going to have to sort of start limiting the questions. A question that comes, are there any signs that the bullying of midwives is being successfully tackled and reduced? And that one really is for Elsie, and I'm not sure whether or not Elsie will know.
Well, as someone who has been bullied myself and supporting still people who are complaining of bullying, and knowing the work that Roger Klein is doing around bullying and the work, situation in the workforce, it's really difficult to tackle bullying, really difficult. And certainly in terms of midwives, we work in a hierarchical situation, and it's something that is going to be ongoing for a long time, I think. Many midwives have been bullied out of, or they will tell you that they have been bullied out of their workplace, out of their careers, and so on. But there are a number of organizations that are working with nurses and midwives, well, let's say registrants, to help them to manage that situation. But it is a recognized feature in healthcare, bullying, and certainly social care as well. So it is a problem. It's been a problem for a long time. I myself went through it, and I have to tell you, it was not very pleasant. And the effects are very, very long lasting on the individual, but also on the profession.
And just one final question, Elsie. Do you think that the risks that women face, do you think that they are now being properly addressed?
I think in theory, in terms of the body of knowledge that's being developed in the midwifery profession, but also outside of that, but I'm thinking primarily as a midwife, and how we work with families, it is being looked at. In terms of the maternity policy for the country, we've always been looking at that. Baroness Julia Cumberledge in 1993 put forward changing childbirth, which, you know, we made this attempt at. It's sitting on the shelves. The Association of Radical Midwives have put through many things around education, but also midwives' ways of working. The Independent Midwives UK, same situation. And there's, you know, we know as midwives what works, but actually getting policy into practice is just, there is something that is actually stopping that happening. Perhaps Chloe is on the path that will make things really happen now, backed up by the extant maternity policy and the commitment of the government, I should say, and our own MPs in, you know, trying to make a difference.
Yeah.
And then we have stuff coming in from the states as well, which is actually highlighting that this is not just a national problem. It is from other countries. And then we have the International Confederation of Midwives, who is working worldwide, but that also includes us, you know, so maybe we will have, you know, a change.
I know I said that was the last question. We've had another question,
right, okay.
which you know, we are going to have to draw to a close soon. But someone's a great talk. How do we as midwives in the NHS who don't work in continuity of care improve our care for Black women and improve outcomes other than by listening? What direct action can you advise, please?
Right. So there is a midwifery, nursing and midwifery competence from from New Zealand, cultural safety. It's really about shifting the power balance. It is about understanding how to develop a therapeutic relationship and to recognize, I guess, that it is not about us as a clinician, it's all about the women. We have that embedded in the NHS constitution, that the voice of the patient, they say patient, the woman is paramount, and we are not there to impose our judgments on her. We have a lot of legal stuff around, so the Montgomery judgment in particular tells us that unless somebody lacks mental capacity to make a decision, they are the decision makers. We may disagree with it, but we are responsible to make sure that they have the information so they can make the decision. Because when we walk out of their lives, you know, they're left to pick up whatever pieces we have helped to create for them. So we need to work with people and recognize it's not about us, it's about the therapeutic relationship that we have been trained and given the ability to give.
And of course, I suppose we can't sort of, you know, close without sort of mentioning, I know we have mentioned it, but basically Montgomery, Nadine Montgomery's case in 2015, which was around the issue of consent and ensuring that, you know, women are very much a part of the consent process. And I suppose, you know, I suppose a question I would like to ask is, when do you feel, because if you imagine in round sort of birth, things can suddenly go wrong and you may not have time to go into all the complications that can occur. I mean, would you agree that all of these discussions should happen, you know, a long time in advance, you know, so that the mother is clear that, you know, if things go wrong, this can go wrong, that can go wrong, you know, and what treatments are available?
Yes, but and that in itself is a bit of an issue, because what you don't want to do as a midwife is to frighten the women. But we do have to have that discussion beforehand. And this is a good thing about having continuity of care of some sort anyway, so that we can actually develop that relationship where there is trust and an understanding what it is that this person will need. So for example, somebody is asking for a test that would highlight a deformity in the baby, but she may not understand that actually to have this test means that you may get a result that, are you going to have what are you going to do with the information from it? Does she really need to have that test? Do we have that discussion? So then when she's making a decision about having the test or not, she understands fully. But we can't, I doubt that we're going to sit down and describe absolutely everything that can go wrong, because that is absolutely impossible. But for me, particularly and personally, when I'm talking to women about these sorts of emergencies, and it's particularly around a home birth, it's like one of the worst things that could happen, or most challenging things that could happen, is if we have a cord prolapsed. How would we manage that? Well, we would manage it by making sure that whatever is going on, the mother is aware. So we're jumping on the bed, we're running to the theatre. And this is what I say to them. We have our fingers in the vagina to keep the head off the cord. And we're getting on that bed and we're running to theatre, because actually we don't have a lot of time for action, for saving lives and damage. And we're speaking to the woman and making sure that she understands, we're doing this for this reason. All will be well, but we have to move fast. And not forgetting the partner in the corner, because somebody is also attending, that they're not just left to thinking, oh God, my wife's going to die or whatever, that they also understand we have an emergency. However, we're on it and we're doing the best we can, but we have to move very quickly. And after the event, we will come back. And then we have a full explanation. So and a lot of that is to do with trust, because part of the process of moving in an emergency is that the woman is as calm as possible, really. So she must have some sort of trust that things,
yes.
And especially in times where we have this situation where, if it's, say, for example, a Black woman who is aware that this is 5 times more likely to die, 5 times more likely to die in childbirth, it's not necessarily correct. It's not in childbirth, it's for the childbearing year. But they will have that, and they might panic and actually raise up their adrenaline levels. So it's a lot to do with the physiology and how you manage those things as well. So, yeah. But very complicated, and a lot of it is embedded. But
no, I know, brilliant, lovely. Well, sorry?
We can do it.
Yeah.
It's just a matter of, convincing the commissioners and the people who hold the purse strings and the people who will help us within the structures that exist to make a difference, because we can do it.
Yeah. Fantastic. Thank you very much. Chloe, finally, I would just like to ask you how people can support your campaigns.
So with 5 times more, you can go on our website, which is fivexmore.com, and on there we got resources on how you can support us. Also on social media, we are at 5xmore_.
Fantastic. Well, I'd really like to thank both you and Elsie for a really stimulating and interesting afternoon. And I hope that people who have tuned in have also found it interesting. And I'd also like to thank everyone who's attended to listen in as well. The next webinar is on the 13th of October at 4 p.m. and the topic's going to be menopause and perineal injury, which I think will be a very interesting topic. And we hope you'll join us then. So thank everybody. Thank you all for coming, and thank you to our speakers who were absolutely brilliant. Thank you.